No, that's a good comment, Jonathan. Thanks so much for including me in this discussion. I enjoyed your presentation very much. For me, the turning point, and you mentioned it in using the ICL, was the centriflow hole. And it's interesting that my friend Tobias Neumann from Munich for 15 years now has been punching that hole in ICLs on his own. This idea took about 10 years to be embraced by technology. And the key thing with the centriflow hole in the ICL is that, number one, you don't have to do a laser iridotomy, which is always not a good thing, in my opinion, in a very high myope. Number two, it tends, since aqueous flows through it, to hold the lens a little further away from the crystalline lens. As far as its use, I'll share with you my personal practice. I'm going more and more on the ICL on myopes that are over 8 to 9 diopters. In the whole of Germany, ophthalmologists have come together and have agreed that no laser surgery on the cornea is done for myopias of 8 diopters and over. So there, the great options that you mentioned are the rule for higher myopias. We know that in the US and throughout the world, laser correction has approval for some lasers up to -14. But considering the optics of very high myope, the fact that most high myopes, in my opinion and experience, get early cataract formation, probably in the late 50s, early 60s, and the window of opportunity of them to have good quality of vision, I would discuss it with any patient that is over 7 diopters as a means of it leaving after its removal, when the cataract evolves, the eye with better optics than if you had changed the cornea surface dramatically. So in my practice, I do a 1 ICL for every 10 laser procedures on the cornea. Okay. Sure, absolutely. Oh, sure, fantastic. Well, we're looking at anything that's comfortable for the surgeon. We ideally want a volt that's over 150 microns, because this assures that there's no contact between the ICL and the surface of the crystalline lens. But again, like everything in life and in surgery, the bigger the volt you desire, sometimes you may end up having a volt that's 500 microns, and then your lens is uncomfortably sitting high in the anterior chamber. In my experience, and I've done hundreds of these, I've probably done close to 100. We've only had one case that the calculation of the lens diameter did not work out well, and the lens was sitting very flat in a lady, and it did aid in an anterior capsular cataract. And the little pearl here is that in some of those very high myopes that have used, for obvious reasons, contact lens use, the limbal architecture sometimes is a little bit difficult to define, both for the clinician and for devices that measure white to white, because for someone who wears for 20 years lenses 18 hours a day, there is some opacity developing in the margin of the cornea, and that may throw off the measurements a little bit. So the ideal volt for me would be somewhere between 150 and 200 microns. So correct half a cornea thickness, roughly. It's kind of similar if you guys have experience with scleral lenses. It's kind of a similar distance, same distance that you want the scleral lens from the apex of the cornea, 100, 150 microns. you want to see a similar picture on anterior segmental CT with the ICL. Okay. Thank you, Jonathan. Excellent talk. Really enjoyed it. All right. So good morning, everybody. It's early or Friday evening for us here in Athens. It's really a pleasure to be with you guys. We have two options, and we discussed this. We can run through some videos of the three most common cornea-based refractive procedures, PRK, Lasik, and SMILE, and then talk about a review of potential complications to their management, or do this vice versa. It's up to you guys. Which one you want to do first? Want to go through the video of the procedures maybe first, and then talk complications? Videos first. Okay, videos. I'm going to share my screen. Okay. So are you, do you all have my screen in your monitor? I'm going to start with PRK. Okay. Let me see. Need to get this to play. Try and play this with QuickTime Player. Okay. All right. So we'll start with PRK, and through this video, I will share with you. Is everybody seeing the video screen? Okay, great. All right, so this is a classic laser vision evaluation. The Optos has been great looking at peripheral fundus exam. We're picking up one tear every 100 young myopes that we're screening. And for me, this is a pivotal step of deciding whether I'm going to advise for a young myope, young meaning anybody younger than me, younger than 55, to have Lasik or PRK, because that's always the question that comes up. What's best, Lasik or PRK? And you will obviously create, as you move along and do both of these procedures, your preference. But it's always puzzling to choose between the two. This is an anterior segment OCT map of the cornea, and it is, and we've reported extensively on this, a little bit more accurate in measuring cornea thickness. And we're seeing that map on the left, which is a total cornea thickness map. Thickness is not bad. Minimal thickness is 500 microns, as we can see here. So for many LASIK surgeons, this would be a good area to do LASIK if we're talking about a -6, for instance. What I don't like here is the epithelial maps. The epithelial maps show a tendency of them being thinner in the center, thicker in the periphery, and the family has some children with strong keratoconus suspicion on scientific imaging, meaning your pentacam. So I'm trying to paint the picture here why we chose PRK. This is the other eye, and we can see the same flavor, minimal cornea thickness 503 on the OCT. And again, the epithelial thickness, and these are now the pentacams, where again, the astigmatism, not a strong astigmatism, but there's certain truncation of the astigmatism. Let me go a click back on the first eye, the right eye, because this for me is an important finding. You can see that the cornea is steep, goes flatter, 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 but this gradient in cornea curvature is a little bit steep, and the astigmatism is certainly truncated. Do we all understand what truncated means? The bow tie of the astigmatism is narrower than the 9mm diameter we're seeing on the pentacam. The bow tie is here quite narrow. It's down to 3 millimeters in length. And then if we go at the thickness maps for the pentacam, you see that these maps are not in gradients that are circles and centered in the center of the eye. they're a little bit oval that tend to skew temporally, and there's more steps than the classic 2 steps we see in cornea thicknesses. So this again for me is a little bit tricky. The back side of the cornea again is not very symmetric. The front side of the cornea, as you can see, has the apex a little bit off center, but this could be due to angle kappa. And when you're evaluating your pentacams, your angle kappa is down left where it says pupil center. It has the pachymeter measurement at the pupillary center, that's 527 microns, and then the X represents the deviation between the cornea vertex to the pupillary center. So theoretically, that's the angle kappa, and it's very little. It's just 80 microns on the x-axis and just 10 microns on the y-axis. So here, if we want to beat this to death, in my opinion, we're seeing a very, very tiny keratoconus that has never blossomed. But, you know, this may sound extreme. This is the other eye, a little bit smoother, more centered apex. And then we're going to see more of the diagnostics. You can see the underlining of the truncation here on the placido disc imaging of the cornea and the other eye. So our decision, this being a lady close to 40, mild myopia, this is a new technology that combines wavefront scientific imaging and action length measurement. It's called ray tracing, quite complicated, but it kind of gives you a good estimate of the refractive error. We'll talk about this maybe some other time extensively, and I always do interferometry in order to confirm that the myopia in patients is axial, and it's not due to, for instance, spherophakia, because in a patient with spherophakia that shows false myopia, you don't want to do cornea-based laser surgery. So this kind of sets the record that this is axial myopia. Pupilometry, we've reported on using your Pendicam pupil, and this is our flow sheet. It's still in paper. We want to track who is filling out the numbers. So one eye minus 4.5, the other minus 2.5, so relatively medium to mild myopia. And these are all the technical data that are used in order to choose the images that the Innovise software, that is the software that does ray tracing, uses to come up with the refraction. And you can see here that subjective is a minus 4.5. The ray tracing software comes up with a minus 511. 0.19 and 32. I'm not going to go into why and what are the advantages in choosing this customized platform, but we're going to continue seeing the other eye numbers. And on the laser, you can obviously, most lasers, you choose your optical zone. Some lasers, you can choose the transition zone. A key element of reducing spherical aberration, and we're going to talk about spherical aberrations in our complications section post cornea-based laser refractive surgery. And you always want to confirm data. Unfortunately, I've seen many times treating the right eye with left eye data or treating a patient with another patient's data. So it's quite crucial to do all this confirmation, just like you do in your cataract surgery timeout. Come in the laser room, do a 5-second timeout, confirm patient's name, age, birth date, with the numbers you have on both screens. Remember that patients are in shock. Any questions that you will answer them, they'll say yes. So don't rely on what patients say. You can ask your patient in the laser room, is your name John Kanellopoulos? They'll say yes. So remember, that's not a very objective way of confirming patient and data. These technologies, fortunately, do not go forward if they don't recognize the pupillary architecture they have done in the diagnostics. So that's an indigenous safety measure to treat the correct data on the patient. And obviously, you want to do all this confirmation algorithm before the patient is in the room, especially in your first cases. You want to be doing this with the patient under the laser head, because that will just increase anxiety. You can see here is a typical Greek patient. There's a lot of eyelid and eye movement. I like to drape with Tegaderm stickers the eyelids. We've brushed the eyelids with swab stick with betadine. Used a drop of moxifloxacin before we begin. Just so I make the disclosure, I do consult for outcome, but I do want to share with you that all lasers, both used in the US and internationally, are very close to each other in accuracy and efficacy. So I'm going to try and be as much as commercial bias free here. Draping the eyelids is also a good test to see if the patient will comply with the procedure. Obviously, PRK is very easy. And here we'll see another technology that's not new. It's used in the US for a couple of years. It's called EBK or ORCA. It's a plastic, non-sharp instrument that is used to remove the epithelium. So you just rub it over the dry cornea surface. The novelty here that we presented the last 2 years in meetings is that I'm going to try and do a very small de-epithelialization, the smallest possible to fit my ablation. It's a little tricky because this device is a little bulky in order to be very accurate in removing small amounts of central epithelium. And obviously the purpose here is to have the patient re-epithelialized. We found that invariably all patients have re-epithelialized by day 3, which is a paradigm change for PRK. So we've called this mini-PRK. The tricky thing here, if you're removing the epithelium manually, and this holds true with using diluted alcohol as well, is you have to make sure you're seeing the shiny bowman's surface all around, and there's no little island of epithelium left behind. If the patient had a sterile corneal ulcer from the contact lenses in the past, they may have a patch of epithelium that doesn't want to come off easily, and you do not want to leave that behind, because once the laser ablates the stroma, it's going to leave a patch of untreated area. So here we have, you can see here again that I've only cleared an ovoid of about 6.5 or 7 millimeters diameter vertically and about 7 millimeters horizontally. And this we'll see during the laser procedure will be sufficient to fit my ablation. The laser here is a flying spot laser at 500 hertz. So treating the first eye, which if I remember well was a -4.5, will take under 6 seconds. And this is real time, and you can see the laser spots. You can also appreciate a very important part in laser, excimer laser evolution is that the spots do never hit the same spot again. They kind of travel across the surface of the cornea in a random order. And this is done in order to avoid having the next spot laser through the ablated tissue plume that comes off the cornea. So thus increasing the efficacy and the homogeneity of the laser ablation. So you can see now my ablation, we said it was a 6.5 diameter OZ with a 1.25 TZ. Breaking here with some lasers helps, and there's various reports on this, reducing post-PRK haze, because you're allowing the cornea to cool down, and also make sure that the surface is homogeneous. We're applying here Myomycin C, 0.2% or 0.02 milligrams per ml. We were based in a southern European country. We have sunshine almost 365 days a year. So it's common to have to deal with cornea haze after PRK, thus the precaution with Myomycin Rinse. I'm sure you're all familiar with this, even from glaucoma procedures. Rinse very carefully with chill BSS. This is the most unfavorable part of the procedure. And then start topical drops. We found a game changer, Bronfenac. Commercially, it's Prolensa in the US, it's Yellox in Europe. We have a little bit of a higher concentration in Europe. It seems to have made the trick for these eyes to be completely painless the first night, taking away one of the major disadvantages of PRK. And please interrupt me if you have any questions in technique. A bandage lens that has been also soaked in Bronfenac while we were performing the procedure in that eye. So sit on the cornea and act also as a sponge that will release Bronfenac. And obviously, steroid and a fluoroquinolone, and we're done. The beauty here of having such a small area of epithelium deepithelialized, not using a transepithelial approach, some excimer lasers give you the option to remove the epithelium with the excimer laser, is that this lady is going to stand up from the laser bed and is going to have 20/20 vision. And it's going to be really, she's going to be relatively comfortable the first night. No pain meds. Certainly, and I strongly discourage this because many clinicians are using it, giving patients diluted topical anesthetics. And we'll see a disaster case later on that. They get a little fuzzy between day 2, somewhere between day 1 and day 2 when the cornea reepithelializes in the center. And of course, we explained this beforehand. But this approach has made PRK more similar to the lamellar refractive procedures, Lasik and SMILE. And we'll go to the other eye, which is pretty much same theme. I'm going to fly through this. Again, just show you the small area that's deepithelialized, and caution that you want to make sure that this area will fit your ablation. You do not want to leave intact epithelium at an area that the laser will ablate, because then you'll have a irregular ablation. So this takes a little bit of experience. And obviously, if you're going to start with this in your first PRK case, try and go halfway of deepithelializing the whole cornea or that small area that I have done here. You want to make sure that you're not lasering through even a small island of intact epithelium. So this is the mini-PRK technique. Most eyes, this is on day 3, believe it or not. Lenses off, cornea reepithelialized, not 20/20 yet, but 20/25. They reach the 20/20 at the week interval, day 6 or 7. And of course, here in Southern Europe, we really work on agents that reduce haze, such as vitamin C, 1,000 milligrams per os per day for 2 months. Strict use of glasses, real sunglasses that hug the eye, not glasses that are there as a fashion statement, and a cap for a full 2 months in order to avoid haze, even in light myopic cases. And this is an image of this patient on day 3 or day 4, and you can see the complete, I want to go back to the cornea epithelium map, because we use these to assess epithelial healing. You can see that right at the border of my deepithelialization and the ablation, there's still an area that needs to remodel, but the cornea has reepithelialized nicely. It has an area here that's thicker, and by observing cornea epithelial maps, you can assess quality of vision and level of dryness very accurately, and correlate the patient's symptoms and sometimes complaints postoperatively with the imagery that you have on cornea. This is amazing technology. We've had it available for the last 12 years now, and we've reported most of the body of the literature on using field maps derived by anterior segment OCT back then and 10 years ago. So, and our Pentacam maps, we're using it to confirm the centration of the ablation, et cetera, and this is what you get with most excimer lasers today, a very uniform, very broad ablation. Some of the old problems with halos and night vision problems, even in mesopic conditions, came because the older broadbeam lasers had an effective optical zone of treatment, 4.5 millimeters. Here we're seeing on the Pentacam that we're over 6 millimeters. Don't think that this ablation is decentered because it's centered on the corneal vertex automatically by the laser. That's why there's a little bit of a discrepancy on the cornea thickness and the effective ablation zone that you're seeing. So that's mini-PRK. Any questions on PRK? Sure. Well, obviously that will alter your transition zone and will make it a little bit steeper. So it's nice if you know the total optical zone designed by the excimer laser to kind of go a little bit further out with your EBK device. The good thing with the EBK device is that the borders of the deepithelialization tend to have steps in the periphery from going from bone lens to a very thin layer of basal epithelium, then thicker and thicker. And this is why these eyes, the theory behind why these eyes epithelialize so fast afterwards. We've not seen any problems with irregularity in the optical zone, but my anxiety is always, and you bring up a very good point, Jonathan, thank you. My anxiety lies always with whether I'm going to miss an island of epithelium somewhere here, and this will leave an irregularity in ablation. But if I go to the borders of my epithelialization, this border here is not sharp. It's kind of a set of stairs that come down from the epithelial surface down to the basal layer and bone lens. And you want to make sure that you have enough space to fit your ablation, and including your transition zone. That's a good point. Because otherwise you're narrowing your transition zone, and you're, number one, having a narrow or no transition zone will encourage the epithelium to remodel and regress your myopic correction. Number two, you'll have more cervical aberrations and night vision problems. So this is one of the things you want to avoid. Sure, good question. I will go to LASIK. I've chosen LASIK Extra not because I'm a strong believer of this being a routine procedure. And I remember Dr. Khan receiving the best resident paper at the AACRS for presenting LASIK Extra and hyperopes. This is many, many years ago. But because we had the opportunity of having a tremendous Italian film guy from Milan, and we're getting very good captures. And I want to stop and go in these captures to share with you some of the points of LASIK that I think are very important in the everyday LASIK practice. Now, this is the refractive suite by Alcon, but as I mentioned, most excimer lasers today are excellent and over and above what you can wish, or what we used 20 or 25 years ago. Here, this is the Femtosecond Laser. Obviously, in LASIK, you need to use two devices. You need to create a flap, either with a mechanical microkeratome or a Femtosecond Laser. Here, we're seeing the parameters that we're designing the LASIK flap. You have the ability to design the flap diameter, the flap depth, the transition edges of the flap. I just reviewed a paper of 40,000 cases from Italy, and how many of those were avulsed or moved by trauma. Don't get scared, only 9 of 40,000 patients, and none had a significant visual sequela afterwards. But Femtos came to the limelight initially because you can design a more vertical edge of the flap than your microkeratome, which comes in quite smooth and thus is more prone to epithelial ingrowth and or sliding and or having the flap avulsed or moved. So obviously we're timing out here again, confirming patient data. One thing in Greece in particular, I think it's the same thing in Italy and Spain, is some young adults have first cousins that have the exact same name and very similar birth dates. So you have to be very careful. We've done, I can remember the same day, 2 first cousins that had the exact date, and they had like a month birth date apart. So I don't want to sound an overkill, the safety feature, but I have seen it many times using wrong data on the wrong patient or transposing axes in laser vision correction. And I've worked with a team in Chicago recently in trying to fix that. It's a little bit of a headache. Here, we're showing that in this particular laser, the patient interface, in most excimer lasers use a disposable patient interface. comes calibrated for the factory. And this particular femtosecond laser, this is the FS200. I think it is the most popular in the US right now. That and the Zemer recalibrates when it sets into the laser. Again, very important here, I'm trying to show you that the orientation of the head, and this holds true in your cataract surgery as well. I'm sure that your cataract surgery mentors will spend a lot of time with you on making the patient comfortable, bringing the patient's head in a horizontal position so you in your surgical field will not be operating on a tilt. You can see here, plus this is uncomfortable for this young lady because her neck is stretched out. So I have the ability to raise the headrest and number one, make her, or move it, make her more comfortable and bring the surface of the cornea in a more horizontal position. I'm going to tilt her head leftward so I can remove the nose from my field. I don't want the nose to push on the patient interface and give me improper applanation and suction. So these are measurements you need to do and adjustments beforehand. Some patients tend, through anxiety, to move. Many patients tend to crawl into the fetal position, so bring their chin down. In our first surgeries, we tend to push a lot downwards, thus moving the cornea plane sometimes behind the palpebral plane. For most people, the cornea is over the opened eyelids. That's another important thing when we start doing intraocular surgery. Again, the tegaderm draping of the eyelids that, as I mentioned before, Lasik began as an in-office, a very nonchalant procedure, and we've encountered back in the 90s some tremendous catastrophic complications with infections, et cetera, and we have to remember it is a procedure. Some people will argue whether it's an intraocular procedure or a surface procedure here. Very important point for femtosecond laser. See how I'm going to leave a crescent of sclera that's more wide superiorly than it is inferiorly, because I'm going to try and bring the hinge. This will make a superior hinge, this femtosecond laser. I'm going to try and bring the hinge of the flap further up, so the clear space after the flap is lifted is centered to the pupil. And we'll see this when we lift the flap. This is a little bit pearl. I'm moving in, and I'm exaggerating here, the PI to make sure that I'm pushing on conjunctiva about 360 degrees. You want to be tilted when you place your patient interface because you may have incomplete suction. You want to make sure that you're pushing onto the conch to have it sponge on the conch. Now my patient interface is applanating on the surface of the cornea, and it's very similar in SMILE as well. The difference in SMILE is that the VisuMax has a curved patient interface, and there's less applanation. Patients feel less, and there's less suction, so patients do have vision throughout the procedure. And this is why I chose this video. We can see side views, and what's important here, I'm going to track back a little bit, is you want to make sure, and this is when we start doing procedures with colleagues, is you want to make sure that your speculum is under the patient interface. Obviously, there's pressure going in from the device to the patient's cornea. We always have an assistant check the position of the nose and the patient interface. We don't want this patient interface to be pushing on the nose because this will give incomplete applanation. And now here we're confirming the position that the femtosecond laser is going to carve, if I can use the term, the flap. See that since I'm displacing my hinge a little bit superiorly, my pupil is centered to the distance that is going to be left open in stroma after I lift my flap. So I'm not centering this circle to the pupil because my hinge is going to encompass in the clear area that I can ablate. It kind of matches what we talked about before on the area that you want to deepithelialize. So my plan for femto flap is a little bit decentered superiorly, and this is a lamellar cut of the flap. I've come to use 110 microns as my gold standard the last 10 years, and then a quick side cut. This was real time, so it takes just 6 seconds for for this femtosecond laser to perform the flap formation. Check out the time, we're already at a half hour. And we're seeing some side view images. So femto part is over. We're going to do the same thing in the other eye. I'm going to speed track this, and then the patient is going to be moved. It's quite nice if you have a swivel bed to move from the femto to the excimer. The Zimmer laser actually swivels into the bed under the excimer laser. So there's a lot of ergonomics involved in for the surgeon, for the patient to be the most comfortable in LASIK procedures. So this is the tracker device for the excimer laser. I use a disposable cannula as my sole instrument that comes in contact with the patient's cornea. And we'll talk a little bit in the next session of complications. Why is that? I do not want to reuse any instrument that will come in contact with the cornea or the cornea stroma. So this is a sterile, disposable irrigation cannula that at this point of the procedure, I'm using it as a forceps rather as a curved spatula to lift the flap. And I want to go back in femtosecond laser flaps. The flap is not created, it's separated. So there's still micro adhesions between your flap and the cornea. And it's almost impossible to start separating from the open side of the flap to the hinge. It's always more practical to start at the hinge, because now you have resistance from the rest of the flap, allowing you to dig in here, push towards the hinge, and then release the flap the other way down. So I'm releasing the flap, the last adhesions from the vertical cut of the flap. I like to always fold the flap onto itself. Some hungry, I guess, colleagues call it tacoing the flap. The reason I'm doing this is because I'm reducing the chance that any particles that may be present in the laser room will land on an open flap that's been placed upside down and just hanging open. Number one. Number two, I'm reducing the amount of dehydration that my flap will have during my excimer ablation. Now, this is a very crucial point for those of you who will endeavor in cornea-based laser refractive surgery, because once you reach this point, everything in the laser room has to be ready. This is not the time, once you lift the flap, to stop wondering, is this John Kanellopoulos under the laser? What was his myopia? Oh, -6. And then the patient says, well, doctor, I thought I was a -5. And then you stop making all this conversation and you're adjusting your laser numbers, and you leave the cornea like this for 5 minutes. Once you lift the flap, you should all hear somewhere in your head a ticking clock that ticks dehydration. So if you leave the cornea 5 minutes as so, you may end up with a underlying cornea. If the flap was 110 and the cornea thickness was 550, you have about 460 microns centrally in the cornea. If you stay like this for 5 minutes, those 460 microns may turn out to be 400 microns. And thus your ablation will have a much stronger kick than what you have planned for. So very important, and this is a crucial part for beginning LASIK surgeons, to, before the patient enters into the room, make sure that you're familiar with how the excimer laser works. You sit there, you know what button, if the pedal is set for your foot to press on, if you're going to do it with or without your surgical shoes, if your team is ready with the numbers, et cetera, et cetera. So here, the next step should be your technician will say, you're ready, I'm zooming in my excimer laser, and this is the excimer working in action. And you want to make sure you're not staying close to this with your spear sponge, because your spear sponge may actually block some of the ablation. That's an important part. Hands off when this happens. You can see the tracker tracking on the right hand of the screen. And in this particular case, we used the riboflavin to perform LASIK extra. But that's not important. The important part is that once we finish the soaking, let me go back to this point. Okay, so we finished the soaking with riboflavin, and now we're going to close the flap very carefully. We're going to rinse carefully the flap and reposition the flap in place. I use a bandage contact lens in LASIK eyes as well. And this is my technique of repositioning the flap in place. Besides Some surgeons liking to mark the area that's going to include the flap and the residual cornea, so thus those markings will match after the flap is repositioned. I like to use a suspension steroid, and I'll show you why. It will delineate the flap gutter. I will use a Johnson applanator. This is a lens, a very broad lens of 30 diopters in curvature, so it's flatter than all corneas, to push centrally on the flap and thus push away all the little wrinkles that the flap may have. Because remember, if you're treating -6, -7 myopia, you're going to remove part of the stroma in a lenticular fashion, and then you're going to have the flap come over it, and the flap will just fall into that little pit, and it may wrinkle. By using the Johnson applanator, you're moving, or you're hoping you're moving some of those wrinkles towards the periphery of the cornea where they don't have any visual effect. So again, I want to show you some close-up views of how we're rinsing the flap. Again, remember, my cornea plane is over the speculum. I'm not pushing towards the eye, because then the eye has a lot of spring motion. You can push it way under the speculum level and be having all this stuff within your surgical field and making your life difficult. And eczema ablation here on a side view. And again, I'm going to go into the rinsing part and how I thoroughly use now my disposable spatula that I talked about before. That's essentially an irrigation cannula. See how that cannula is curved? Actually, this particular one is designed by Peter Hirsch of New Jersey. And how I'm using the suspension steroid, not just for anti-inflammatory purposes, but to delineate the gutter and give me the definition that my flap is sitting exactly where it should be. If my gutter is thinner on one side and thicker on the other side, that tells me that my flap has landed skewed towards the thinner gutter side. And if my bottom gutter, so the gutter that's at the free end of the flap, is very thick, that means that I have fluid somewhere in the flap holding the flap up. And I do not want to leave that flap that way, because I'm going to end up with striae in the flap. So I use the Johnson applanator. This is something that not many surgeons use. And you can see here very nicely how the gutter of my flap is delineated all the way around, and it's homogeneous. So this is my pearl of fitting flaps in the perfect position. And then have the patient come up, stand up, and watch the clock on the wall, smile. That's what we all work for. And we're all done. So that is a typical LASIK procedure for me. We've posted many of these on our YouTube channel from our Laser Vision Eye Center here in Athens. So you're welcome to watch many of these procedures on our YouTube channel, besides the small palette we've created here with procedures. We'll take a few LASIK questions if you have, and we'll finish our cornea-based laser surgery with a smile case. I'm not sure everybody's online. Okay. Can everybody hear me? Okay, great. Sure. You're welcome. How do I enlarge the screen of all right, so we'll finish our venue here, our trip through laser cornea vision correction with SMILE. SMILE is relatively new. It's not a new procedure, but it's gaining fans and among clinicians as well, because it has some intrinsic advantages over PRK and LASIK. We'll go over them while we see the procedure. As a preparation and execution is very similar to Lasik as far as the use of the femtosecond laser. Its only intrinsic difference and maybe difficulty is fishing out that lenticule from a 60-degree smile incision in the periphery of the lamellar cut. And that's the only tricky part. For a good anterior segment surgeon, it has a very short learning curve, just a few cases, but there's a few steps that you need to follow in order to avoid hardship with this procedure. So we'll go through our usual nomogram. I hope you're seeing what I'm seeing on the screen. This is a case from the study that we published. We have 3 peer-reviewed articles on this, comparing one eye smile, one eye LASIK. And in essence, we found that both procedures were excellent in correcting myopic and myopic astigmatic refractive error. And again, the same theme here, evaluating the corneas with all modalities. See how the astigmatism in this eye is not truncated. See how the bow tie goes almost from one side of the pentacam map to the other. Pentacam sees only the central 9 millimeters of the cornea. The back side of the cornea has a few colors. We have angle kappa here, 350 microns on the x-axis, 270 on the y-axis, so significant angle kappa. Again, actual length measurements to document that the myopia in this patient is axial myopia, and then pupilometry to make sure that our ablation or our planned ablation zone will address most of the mesopic pupil demands of the patient. Although in my personal opinion, matching scotopic pupil size with ablation was more of a problem when our lasers were not centering very well. So having halos and spherical aberration at night is not that much a mismatch between the ablation zone and scotopic pupil diameter. It's rather more of the laser delivery not being very well centered on the cornea vertex. But that's a different discussion. It's very esoteric for cornea surgeons. So this is the only device that until now can do the smile procedure is Zeiss's VisionMax Femtosecond Laser. It's a femtosecond laser that can be used for LASIK procedures as well, just to create flaps. And this is how the interface looks like. And we are planning the CAP data. CAP in smile language is the thickness of the cornea that it's going to left behind on the top of the procedure. And the manufacturer recommends that the CAP is 130 microns. So we followed this to the letter. So all our caps in the study were 130 or planned to be 130 microns thick. And then the femtosecond laser by default will carve a 15 micron non-refractive lenticule just to give some bulk on the lenticule that would be created and for the surgeon to be able to manipulate it. So a priori, 15 microns of cornea tissue will be removed. The recommendation is that you treat myopias over 3 diopters, so that 15 microns of central cornea in the lenticule plus the amount that's calculated by the Marmalin formula for the 3 diopters of myopia and up will add up to a lenticule that's going to be close to 50 microns in thickness and over eventually. So the cap is being defined by a lamellar non-refractive cut, and then the actual refractive part of the lenticule is the deeper cut that's curved and has the refractive aim. The deeper, obviously, cut is performed first, so we don't have to go through the superficial cut bubbles. And then the surface cut and the side cut is performed second. So this is basically smile in a nutshell. We'll go here and watch a real-time procedure. Again, this is the patient. One of the comfortable things with smile is that the patients don't black out because the suction from the VisionMax excimer laser, femtosecond laser rather, remains within the 30-35 millimeters of mercury that are not enough to close the ophthalmic artery, and thus the patients can continue to focus into their green light. They'll be blinking during the procedure and retain a, we hope, dynamic concentration onto the centration of the excimer laser. You can always judge a patient anxiety and how they essentially almost jump at the use of extra topical anesthetic and antibiotic. And we're going to rinse the surface because we want to remove any particles that will go between the patient interface and the cornea, the surface of the cornea. But we want the cornea to be relatively on the dry side. We don't want to use thick lubricants because if they go between the patient interface and the cornea, they will reduce the thickness planned with a femtosecond laser because they will increase the distance of the patient interface to the desired location. So we're letting the surface to dry a little bit, and this is a little bit of art. I'm going to jump the gun here and do it manually with a dry Wexel sponge. And then what you're seeing here is the PI engaging. I can't see anything here. This is the surgeon's view. I only see the green blinking light that's going to be the focusing reticule for the patient, and also my guide through the first Purkinje image to center my Femto laser correction onto the cornea vertex. So again, I'm not going to center in the pupillary center. I'm going to center on the vertex. Thus, the area that green blinking light will be seen on the cornea surface. I'm almost applanating. You'll see me touch the cornea in just a few seconds. Very slowly, talking to the patient, have them focusing the green light, coming a little bit closer, and we'll see me touching the cornea now. So you see the area being applanated, and I'm going to use the Purkinje image, the first Purkinje image of the fixation light as my guide. We're not seeing here in this video well the pupillary aperture. And this is the first refractive cut that's performed deep in the cornea. And now my superficial lamellar cut that's going to define that from the cap is a little bit broader. You saw it goes almost 1.5 millimeters more to the periphery. And now the superior smile, we had a vertical cut down here. Let me bring this image a little bit higher. So a 60-degree cut. So in smile, we have almost the exact opposite of LASIK. Instead of leaving 60 degrees of uncut cornea to create a hinge, we leave all the lamellar cut uncut, and we just define a vertical cut at 60 degrees, through which we're going to try and do a tiny cesarean and remove the lenticule. So that's the applanation and the femto working. You see we have about 10 minutes left. And now we're going to have the vision actually remove the PI. We'll focus through the device onto the cornea. The patient, as I mentioned before, has remained with vision. Patient did not black out. We can see here clearly the refractive cut, that's a curved cut, deeper in the cornea, I should say, and the lamellar cut, that's a planar cut at 130 microns depth, and the vertical incision of 60 degrees at the edge of the lamellar cut. And now the tricky thing is to be able to delineate the lenticule and pull it out with the least possible manipulation. So this is the only tricky part, and in essence what we're going to try and do is use this special instrument on one side of our smile incision and define the area that's between the lamellar non-refractive part. So I'm first clearing the microadhesions on the smile incision, and then I'm going to use the same instrument that's basically blunt, go in and then push upwards and define the area that's between the lamellar cut and the residual cap of the smile procedure. So I want to have clear separation between the space between the lamellar cut and under the cap. And that I'm doing on one side of my smile incision. And then I'm going to use the other side of the smile incision to do the opposite, to create a space between the refractive cut, the deeper cut, so now I'm going to point towards inside, deeper into the cornea. You can kind of see the lenticule edge here. I'm not sure if you're getting much clarity on here, but you can kind of see the edge of the lenticule defining itself here as I'm going under the lenticule and creating the space here. So now I have two different pockets, one pocket over the lenticule and one pocket under the lenticule. And it's very important to first separate the lenticule in the anterior pocket. And this is a lesson you learn very vividly if you do it vice versa, because it's very difficult to separate the lenticule from the cap. So you want to first separate the lenticule if you had done the refractive separation first. And see here that with this olive tip instrument, I'm pushing all the way to the edge of the lamellar cut in order to make sure that my lenticule refractive cut will be definitely free of adhesion. So I'm defining the full space of the lamellar cut, and now 360 degrees, and now I'm going to use the same instrument to go under the lenticule, and you can see the edge of the lenticule here, and go straight to the end, and then start separating the sides of the lenticule almost symmetrically, because I want to separate the bottom part of the lenticule coming up and make sure that I'm keeping the sided superior adhesions, because otherwise the lenticule may shrivel and get stuck somewhere on the bottom of the pocket, and it'll be very difficult to get out. So I slowly free the lenticule throughout, and I'm confident here that I've released adhesions 360 degrees, so I'm going to use a toothless forceps to pick out the lenticule, and I'm done. So the beauty with the smile procedure is that this is it. We don't lift anything. We don't have any excimer ablation. The inside of the cornea is not exposed to the air of the laser room. I'm pushing up the residual fluid, and the procedure is essentially done. The vision after procedure, because you have two lamellar and refractive cuts with a femto, is that the 2030, 2050 level. The first day they're at the 2025 level, and the first week they reach similar levels with Lasik. So there is a little bit of a slower wow effect with smile. I'm going to go to the other eye of that same patient if I have it, to just, actually the other eye of that same patient was treated with Lasik, and we saw that before. So I'm going to run back and let's see again the removal of the lenticule, because I think that's the most important part in smile. The rest is just computer logistics. So once we're done with the femto, I'm going to watch this in real time. We're going to break the micro adhesions at the smile incision. And we're going to use this blunt spatula to define the space, the superior space of the lenticule between the lenticule and the cap. And then go to the other side of our smile incision and define the space between the lenticule and the residual stroma behind it. So we want to have these two different pockets created before we start manipulating the space that's under the cap. So then first separate the lamellar non-refractive cut, so the superior cut, with this olive tip spatula. Very careful not to tear my smile. You need to see how we're careful in swiveling the olive tip instrument, not pulling it side by side, because your cap is 130 microns and you can tear its sides and go from 60 degrees to 90 and 100 and 150 degrees. It's very easy to tear the edges of this smile incision. So I'm making sure that my space over the lenticule is clear, all the way around and all the way to its edge. And now under the lenticule, I go all the way to the bottom, and now symmetrically I swivel left and right, coming up towards my smile incision, not releasing my lenticule from one side, because I will not have traction to release the other side. So now I'm releasing completely the lenticule from one side. I'm pushing it within the pocket and bunching it up on the other side, and it's almost completely free. This is the part where if our adhesions are not fully released, by pulling the lenticule, you can leave a little piece behind, and that will not go well with the refractive effect that you are desiring to get with a smile procedure. Same thing if you don't clear the space as we showed, you can get some resistance in removing the lenticule and leave a little piece behind. By the way, in a smile procedure, if something goes wrong, you can always go back to the Femtosecond Laser, enlarge your side cut, and convert the smile procedure into a Lasik procedure. So that's a little bit of a safety feature in smile. Before you manipulate the lenticule, you can still convert it into a Lasik procedure because you have the lamellar cut and so on and so forth. So this is a brief review of a smile procedure. And this concludes our journey through the three major laser vision correction procedures on the cornea. Yes. It's a very good question, and thanks for bringing it up. I'm moving more and more towards using a phakic IOL in lower, so to speak, myopias, meaning people who are over 8 diopters. I started using it in people who are over 12 diopters of myopia. The reason being is that in my personal practice here, I don't know how things are. I'm always forgetting what it is to deal with high myopes in the US. Especially in female patients who are over 6 diopters myopic, they're invariably going to get cataracts, significant cataracts, around their 50s. 50 to 60 is the age that they will have cataract surgery. So now I'm fast forwarding a -8 myope who we treated at 35, 15 years later, that now has a cataract. And by the way, remember that some of these cataracts will first reveal themselves as increasing residual myopia. So this is where you have to go back to your interferometer and confirm that it is actually the lens that it's their crystalline lens that's thickening and not their cornea that is steepening, and they're losing the myopic effect you achieved with your Lasik procedure. So if we go now at 50 years of age and we're performing a cataract procedure in and I'm going to say young lady because I'm seeing almost 3-to-1 keratogenesis in females versus males with high myopia, you have to deal with some very distorted cornea optics. Besides the fact that you're going to use an aspheric intraocular lens, still these patients will have poor quality of vision at night. All myopes that are over -8 do not have the same visual performance after LASIK with myopes that are -3. And they know this, and in my opinion, they don't complain about this because that's the same way they see at night with their contact lenses in their career of being contact lens users prior to our laser vision correction. So if you put on the table, as now a cataract surgeon, what would I prefer to have? A virgin cornea or a cornea that I've corrected 11 diopters of myopia? Of course, I would prefer for the logistics of the improved optics of that patient, the virgin cornea. So for the rest of their lives, they're going to have a much higher quality of vision. With the lenses we have today, they may have tremendous visual performance. That's one. Number two, phakic IOLs, because they're closer to the nidal point of the eye, magnify. So by default, you have an extra line gained in their visual correction because of magnification. So that can cover up some of the nomogram issues with the ICL. It is clear that the ICL is not as accurate in correcting refractive error as our lasers are today. So even if you're half a doctor off or 3/4 of a doctor off, or your astigmatism correction is a little bit off, it's forgiving through the magnification effect of the ICL. So it's mainly, number one, quality of vision. They have much better quality of vision. Number two, looking ahead of these patients in the, well, relatively near future, undergoing cataract surgery. And if we're talking about female patients, a much gentler, transient, and maybe permanent dry eye profile after a 270-degree vertical cut with a Lasik flap versus a 2.75 incision at the limbus to place the ICL in the eye. And the worst thing that you get with the ICL, because it's far away from the cornea, and if you manipulate the lens with some expertise, it sits behind the iris. The worst case scenario is that they'll develop cataract earlier, and I do discuss this with patients. I tell them that you have a propensity with your high myopia to get earlier cataracts. There's a 2 or 3 reported incidents of anterior capsular keratogenesis, and rather subcapsular keratogenesis with the ICL. If we put the lens in, we'll never know whether your cataract will form due to your high myopia or our ICL. But even if that comes in as a late mishap, again, you remove the ICL. It's the easiest thing to take out of the eye, and then perform your cataract surgery, and again, bring the patient into whatever state you want, ametropic or slightly myopic if you're playing with monovision, and you're able to give them better quality of vision, one. Number two, if you're pursuant of multifocal IOLs, forget about using a multifocal IOL in a patient who had Lasik for -8 diopters of myopia and over. That's a bad combination. And a virgin cornea, you can certainly entertain that possibility. Sure. Great question, Carl. Thanks for asking. For us here in Greece, which is unusual for my New York city practice, is I see almost one hyperope per every 4 myopes. It seems like hyperopia is quite more common in the Greek population than it is in the average patient that I see in the US. Yes, in hyperopes, we do employ Lasik. I have changed my standard there as well. I used to perform hyperopic Lasik all the way up to -6, which is actually the FDA approval level, and the level for most excimer lasers that they can reach up to +6. Now I've moved more to a +3 to +4 as my max. The reason being, again, the significant manipulation of the cornea optics, plus the fact that usually hyperopic patients are patients in their 50s. We usually see hyperopes at age between 42 and 60. So then if I have a hyperope who's a +5, number one, and remember this guy, make sure the angles are not very narrow. You don't want that patient to leave your exam room and get angle closure across the street. Always evaluate angles in hyperopic patients, and discuss the possibility of, instead of for a +5 52-year-old, instead of doing a cornea-based procedure, to perform a cataract procedure or clear lens extraction, or however you want to call it. Now, in the rare occasion, because usually hyperopic eyes have very shallow chambers, that your chamber will be over 2.8 millimeters, you have the option. It's available internationally outside the US to use a ICL for those patients as well. So there is an ICL available for hyperopic patients, taking that they have a deep chamber, which is a rarity. So you do have the option to do that as well. I'm not a big fan of that because we all know that in hyperopic patients, the chamber will get shallower much quicker than in myopic patients. But that's definitely an option. So to sum up, I will treat hyperopes up to a +3 with either PRK or Lasik. SMILE is evolving into bringing an FDA-approved technique that you'll be able to do a hyperopic SMILE as well. It's being used outside of Europe. It's not approved in Europe yet, but I know it's used in Asia, India, and other parts of Asia as well. And hyperopia is another area of interest. You can get a very good Lasik or PRK result in a hyperope taken that they follow the traditional hyperopic tradition that their corneas are flat. You do not want to be performing hyperopic laser vision corrections in eyes that have keratometries over 45, because then you're turning these corneas into very steep corneas into over oblate corneas, which also creates issues with quality vision. So invariably, patients who are hyperopes have cornea curvatures of 40, 41, and that's a good rule of thumb. If you run into a rare myope who has keratometry of 40 to 41, then in my opinion, that's a mixture, genetic mixture of myopic genes and hyperopic genes. But in any case, that's pretty much my experience of what I practice now. And I think this is what most people practice in Europe and the US. They do hyperopia of up to 3 diopters. Although in the US, many colleagues and many friends of mine go directly to multifocal lenses for or trifocal lenses for, let's say, a 50-year-old hyperope that's even 2 diopters hyperopic, because that way they'll be able to deal with both hyperopia, presbyopia, and mid-range vision. I'm personally not a big fan of that, but I know that many people are, and that's almost a standard of care for a large portion of clinicians in the U.S. and outside the U.S. Well, that's the toughest case possible. That's the toughest case possible because you're in your 30s. You're looking at, considering even cataract 30 years down the line. Depending on the cornea curvature, I would consider LASIK as an option. The one tricky thing with 30-year-old hyperopes is that the true hyperopia may not be 6 diopters, may be 8. So if she, for instance, is a real 8 diopter hyperope, then I would jump directly into doing a lens exchange there. That's the only sensible for a +8 hyperope, in my opinion, option, because you're reducing the chance of future angle closure. As I said, especially in a +6, you have to be very careful with the angles of the patient. Unfortunately, most clinicians, in most basic practices, the ophthalmologist sees the patient dilated, and with through the cycloplegia, the lens moved backwards, and they cannot get a feel of what the real functioning depth of the chamber is. But if you cycloplege your fiancée and she continues to love you as much and remain your fiancée after cycloplegia, which I certainly hope so, and you pick up, higher levels of hyperopia, I would certainly wait to do a lens-based procedure or look more towards that direction. But for +4, and if that was a real +4 with cycloplegia and a 30-year-old, I'd feel comfortable doing LASIK. Sure. Do you guys want to take a 5-minute break? Do you have enough energy to go direct to the complications? It's up to you. Okay. So I guess keep going. All right. So we're going to go through complications with our cornea-based procedures. And what I did here is I sneaked into your American Academy of Ophthalmology basic science books, and I looked what's noted as the photoablation complications. We're going to fly through these a little bit. Some of these just make sense. You want to avoid overcorrection, undercorrection. Central islands are a little bit of a theme of the past when lasers were broad beam and the central plume of ablated tissue was accumulated in the center of our ablation pattern and was shadowing the broad beam waves of excimer laser being directed by the device to the cornea. So we're ending up with central islands. So I'm old enough to have experienced the times where the excimer lasers then had an extra patch to overtreat centrally to overcome the central island. This is a thing of the past because with flying spot lasers and what we talked about before when we looked at the ablation pattern and how the flying spot dances around the cornea, you're avoiding getting ablated tissue plume and creating central islands. Optical aberrations is a big thing. And if any of you are familiar with some of the issues that came up with Lasik several years ago, it was actually questioned rather by the FDA whether Lasik should be FDA approved. Is an important issue. It has to do a lot with centration of the ablation. I, as an investigator, have devoted a lot of time and effort in documenting centration of the ablation and delivery by different lasers. But it's a significant issue, and this needs to be discussed with patients beforehand, especially if your laser vision correction candidate is not a contact lens wearer. I want to underline that. Treat patients who walk into your office with $2,000 worth of glasses or Zeiss or NASA design that probably after a laser cornea-based procedure, they may not have that pristine quality of vision that they demand and they want. They may have it, but they may not. So this is a very important point. I invariably, if I run into a patient like that, want to trial them with contact lenses and tell them, this is what your vision is going to be like after our LASIK or PRK or SMILE. Will you be happy with this? And if they say yes, it's a go-ahead. If they say no, you should probably not do that case. And I speak of experience with having dealt with many patients, not many, but enough for this to become an important point for me. And believe it or not, some of them have traveled from throughout the world to Athens to see me and try and fix this. Now, decenter ablation is also one issue from the past. You may have to deal with a patient that was lasered in the late 90s or early 2000s because trackers back then were not as accurate. It's almost very rare, but you have to be aware of that. And again, I made a point when we talked about the ablation that you want to center ablations on the cornea vertex. Remember, the cornea, there's a lot of confusion what the cornea apex is and what the cornea vertex is and what the line of sight is. Remember, the cornea apex is the steepest part of the cornea. So it's not necessarily the center of the cornea. In a keratoconic patient, the apex is the tip of the cone. If there's angle kappa, the apex is not in the center of the cornea. The patients are seeing through what you're experiencing as the cornea vertex, which is the first Purkinje image of whatever is reflected on the cornea surface with the patient focusing on that light source. And that defines indirectly the line of sight. So the center ablation theoretically has to be defined by how centered the ablation is to the cornea vertex. Now, to complicate things even more, cornea vertex tends to shift from photopic to sclerotopic conditions. So which one is the real corneal vertex? I'm not going to go into length, but we all understand that this is an important parameter, and there are techniques that can improve these center ablations. Corticosteroid-induced complications, very important. Remember, 1 out of 20 patients who will use a real corticosteroid in their eyes will spike pressures. And when I say spike pressures, they're not going to measure 21 or 22, they're going to measure 40. Remember the adjustment of corneal pachymetry that needs to be made if they've had a cornea-based laser procedure. And remember that it's going to be 1 out of 20 patients. It's not that uncommon. And it may be you as an ophthalmologist that will save that patient from glaucoma if they're asthmatic and they're using pulverized steroid through an inhaler or a nasal spray for allergic rhinitis, and their pressures may be 40 for 20 years after you see them and you do not pick up that corticosteroid response. Epithelial effects, very rare with photoablation. They're more due to using mitomycin C, so we want to be a little bit careful on the chemicals that we use on the surface, the undiluted alcohol. We want to use pure alcohol to de-epithelialize if that's our theme in PRK, and careful with mitomycin concentrations and time of application. Dry eye and corneal sensation is a key point in laser vision correction. In my opinion, and if you like to listen to some of the informed consent, some of them are in English that we have on our YouTube channels, I encourage you to listen to them. I always talk about dry eye, transient dry eye. It is something that is real, mainly in females. Female patients are lady patients, and we have to be open about it. Usually, the hardship of wearing a contact lens is more than the transient dry eye that the patients experience, especially after LASIK, which lasts mostly 3, max 6 months. But it's real, and we have to address it. Cornea sensation obviously is worse after LASIK than in SMILE at PRK, and you may choose PRK in a known dry eye patient that cannot wear the contact lens, especially if it's a lady and wants to have laser vision correction, despite the hardship of it delaying a little bit recovery, but essentially creating less dry eye than LASIK. Infectious keratitis, really something that we should not see anymore in laser vision correction procedures if we take our precautions, and of course, caution our patients for medication compliance. Unique for PRK are persistent epithelial defects. If you're using mitomycin, some eyes will have significant blepharitis, will have toxicity with topical medications. These are hard to deal. You have to address these. I have several videos on my YouTube channel that I'm showing that if you end up with a persistent epithelial defect that has white borders, white elevated borders, you have to intervene. You have to go with a sterile swab stick and take out on the slit lamp with the topical antibiotic that white border to enable the epithelium to regrow over the cornea surface, because that's dead epithelium there, and the fresh epithelium that comes in periphery cannot jump over that crater. So persistent epithelial defects are a reason, in my opinion, to hold steroids maybe for a couple of days, use tetracycline-like medications orally for a couple of days to increase your epithelialization, take out any toxicity. In extreme cases, I will use even plasma drops. Sterile infiltrates, well, we all know that we have to treat them as if they were infectious infiltrates, but they're usually a headache that comes with the contact lens use. You can identify them as sterile if they're concentrically around, and especially if they're arcuate around the periphery of the cornea, and they may be related to the contact lens. Nevertheless, you have to increase the steroids, and you have to cover with antibiotic. You have to make sure that they don't stain, and obviously treat them with daily follow-up until they've resolved. Cornea haze is probably the biggest issue still to the date with the surface ablation. Some people believe it's a factor of sun exposure, some other the heat created by the excimer ablation, thus the breaks that we saw before in PRK. And as far as LASIK, keratome complications have subsided significantly with femtosecond lasers, but they're not zero. With mechanical microkeratomes, we had the common occurrence in patients who had anterior basement membrane dystrophy or recurrent erosion. Once the keratome slid over the surface of the cornea, it sloughed off the epithelium, and you end up trying to make a flap and trying to avoid an epithelial defect, ending up with a cornea that's de-epithelialized and has a flap. Less of a problem with femtosecond lasers that do not travel or rub against the cornea surface. They just applicate the cornea surface. But again, this is an important point. If your topographies look funny and if your epithelial maps look funny, try and have those patients scanned in the morning, because anterior basement membrane dystrophy may be symptomatically almost impossible to diagnose in the evening hours or afternoon hours. But if it's there in the morning, you may shift in treating that patient with PRK, because that will treat the anterior basement membrane dystrophy or mapped out fingerprint dystrophy, however you want to call it, better than a Lasik procedure. Traumatic flap dislocation, I mentioned I just reviewed a paper of 40,000 cases from Italy. They had 9 cases. It is a reality. It takes a very sharp instrument to travel over the cornea surface if it's been a week over a Lasik procedure, something that will endanger any eye at any time. So I don't think it's an intrinsic problem for Lasik, but we have to be careful the first week not to rub the eyes, not to dislocate the flap. I always have patients sleep with covers, not patches over their eyes. DLK is a thing of the past as well. Since we identified it, we use better autoclaves, and we're using disposable instruments. Pressure-induced stromal keratitis ties in with the corticosteroid-induced complications, because in some patients who are steroid responders and have Lasik, the increased intraocular pressure will result in fluid being accumulated within the stromal interface under the flap. And you may not visualize this because there's a little bit of cornea haze. You're applanating that eye, you're measuring pressure of 10 because you're basically just pushing with your gold applanator the flap against this fluid pocket, and the eye pressure may be 50. So this is an important finding to identify, and you can pick it up on with a proper slit-down examination, but better with anterior second OCTs. Epithelial growth, more of a thing with hyperopic retreatments, and in retreatments in general, you may get healthy epithelium to grow under the flap. Usually, in order for it to survive, it needs a background of blepharitis and a direct link to the surface epithelium. So if you interrupt the link with the surface epithelium, the epithelium will not survive in the flap interface. Treating blepharitis will help. Sometimes you have to lift the flap and treat this. Sometimes you have to lift the flap and suture the flap in place. Another technique in our YouTube channel, you may find it interesting to observe interface debris. This is bad surgical technique. We have to make sure that our laser room is a room at the orthopedic surgery standards as far as particles that fly in the room, people who come in, how they're dressed, how their legs are draped, and shoes, etc., etc. Ectasia is a big issue in mainly identifying keratoconus suspect cases prior to the procedure, any procedure, Lasik, SMILE, or PRK, and encouraging patients not to rub their eyes after laser vision correction. Because in my opinion, any patient who had laser in their corneas that is an avid eye rubber can develop ectasia and keratoconus. But of course, most commonly, patients who do have family history of keratoconus or have suspicious maps in their preoperative evaluation, thus the importance of that, and thus, if you see it, avoid laser or avoid a cornea-based procedure, or if you're going to do laser, do a PRK procedure instead of a lamellar procedure, Lasik and or SMILE. Now, some unique complications for SMILE, suction loss, having an opaque bubble layer not allowing you to see well, and essentially the most common are tearing the lenticule. We talked about this when we saw the live procedure, and you can get ectasia in SMILE as well. It first came out as this is a procedure that does not cause SMILE. And I'm going to run through some examples so we can put all this theory into action. This is actually a colleague, a dermatologist that spent 2 weeks in London, 2 weeks in Athens. She had PRK elsewhere. 2 weeks ago, and she came in the office, classic Friday night at 6 o'clock with this. And John, I'm flying tomorrow morning for London to do my 2-week tour in London and then fly back in 2 weeks. Take a look at the hypopyon. This is always an ominous sign for an infiltrate. Shows either significant inflammation or significant infection. So obviously fortified antibiotics here. She was just on Tobradex, which is a magnificent medication, but not to treat infectious keratitis. Thus, we didn't take a culture here because she was already on tobramycin antibiotic. We used fortified Vanco and cephalosporin, and then we also designed through her placido disc map a spot to treat with higher fluence cross-linking. This is a new technique, and we were able to resolve that within 2 days. We talked about small ablation zones with older lasers. This is one of them, treating -10 myop. This patient is 20/20, but has terrible halos at night. And there is technology with excimer lasers that you can enlarge this optical zone. And we reported this many, many years ago. This is a Femto cataract mishap. This is a OBGYN colleague that flew from Denver to Athens for us to fix this back at the time where topoguided was only performed outside the US. You can see one of the arcuate incision used with the Femto cataract device is outside the, I'm gonna go back to this slide again, designed by the device to, see how I go back on this. Okay, previous. All right, so one of the arcuate incisions to treat the astigmatism is very close to the visual axis, creating this very irregular astigmatic picture. Best corrected here, and this is a multifocal IOL. Unfortunately for the patient, best corrected was 20/50 and tremendous glare. He couldn't operate it. We did a topoguided procedure. We normalized the surface. Very happy patient. You can see the difference before and after and how it mimics the actual cornea irregularity. And you're getting a flavor of how powerful excimer lasers are today in correcting some of the excimer mishaps. I mentioned before that we spent a lot of time in defining ablation centration. This is a in-house developed software, and please don't laugh. Unfortunately, I didn't follow the roots of Apple and IBM and Microsoft, but we designed the software just to be able on the sagittal maps we're seeing on the bottom before and at 1 week. The different sagittal map gives us the most sharp borders, and this is the Pandicam. So by default, these maps are centered on the vertex as the patient is centering in the device. And we're using this software with the XY crosshairs to define the difference map and give us the deviation that the center of this refractive effect on the cornea has from the cornea vertex, and thus define the actual achieved centration of the ablation. And it's different with different lasers. It increases tremendously with cyclotation adjustment with excimer lasers. This is a complication I hope you never see. It's called central toxic keratopathy. It's a very vivid reaction of the cornea to usually PRK. It kind of looks like DLK, but you can see there's a lot of spots of inflammation within the cornea and even behind the cornea. It can cause tremendous cornea melt. We still don't know what causes this. Some people have theorized it may have a herpetic origin, although it manifesting itself bilaterally makes it unlikely that it comes from herpes. The treatment here is reduce all preserved medications, use autologous serum, and maybe a preservative-free corticosteroid for months and months. And you can end up for a patient that, as you can see here, started with a +12 to end up maybe at a +1. This is what happens when the patient steals from the ophthalmologist's office a bottle of topical anesthetic because he learned or she learned that it helps with pain. In Europe, topical anesthetics are given by pharmacists to welders freely. And in my New York years, using in urban New York, I've seen several patients smoking crack developing this. This is an anesthetic toxicity of the cornea, focus not only on the epithelial defect, that tremendous external disease that it's caused, but also on the ectropial pupillae and the correctopia that it has performed, which invariably should make you think about significant glaucoma here. The anesthetic has penetrated the anterior chamber, is working on the lens, the iris, and the angle, and a reason not to use topical anesthetics as a post-op regimen for patients, even if they're diluted. This is the CXL device measurements for the physician we saw before, treated with that CXL spot, making the nubular lesion flatten within a day, actually 12 hours, of course, in conjunction with topical anesthetics. Haze, we talk about haze. This is grade 4. Cornea haze after PRK is graded from 1 to 4. 4 means you can't see the iris. This is obviously caused either by overheating the cornea and or the patient being exposed to sun or UV, and or for them not using medications and or them not using quenchers for UV light, such as vitamin C. It's a difficult thing to deal with. Remember, haze is collagen produced by keratocytes that have come into the picture after they've had apoptosis. They regenerate and they start laying down collagen in a subhazard pattern, creating essentially a scar within the cornea that's very difficult to treat. You can treat with steroids for a while, even create a cataract if you treat it for years. Some of this will regress on its own, but it will take 5 to 10 years to regress on its own. You may go back with excimer laser and myomycin to retreat. This is a late haze in a young patient, 2 years after PRK. By the way, you can see this in patients who climb very, very high altitudes. Himalaya climbers should not have PRK because up there, UV light, even years after their PRK procedure, may have them return with this picture. This is a younger patient that 2 years after his PRK spent a summer in the sun in a beach in Greece and came back like this in September. It was fortunately resolved with topical corticosteroids. Now, as far as LASIK, we'll go through a few pearls with LASIK. We talked about our refractive sheet. These are more practice issues. Remember what you promised patients. These are some ads that are actually out there. But remember, there's a site called LASIK Complications. I invite you all to visit and to see some of the terror stories that are described there, in my opinion, not objectively and very poorly. But remember that it's a procedure. It's very important to assess patients not just as a refractive surgery candidate, but as a general ophthalmology patient, because you may pick up pathology such as a significant retinal tear. As you can see here, had focal treatment and saved an eye in the quest of correcting vision with laser. These patients and their family will become yours for life. We like to evaluate other parameters as well in the field, cell counts. You'd be surprised how many early Fuchs dystrophies we have picked up in younger 40, 50-year-old ladies that came in for laser vision correction. Complete eye examination, some of this is standard for you guys. I'm a very strong believer of a self-contact lens trial, especially if you're trying to present to your patient the option of a mild monovision effect. They're 45 to 50, they're correcting 6 hours of myopia, and you're looking ahead and want to make them capable of having at least intermediate vision. Unfortunately, most patients deal with a laser vision correction procedure as if they're buying things on sale. So they feel that undercorrecting one eye, half the doctor is serving them less or is giving them less for their monies. And this is an important point, you as a clinician, to be able to convey objectively and explain to them why. It's only a trial, even if we're dealing with an ophthalmologist, that will convince them that this works and they will not have problems. By the way, a contact lens trial will prove the eye dominance. I'm not going to go into this a lot. This is our technique of using topography modified refraction, because in a nutshell, many patients will choose a refractive cylinder seen here in red, different than their topographic cylinder. And we have theorized this is because they have angle cap on this. Regular astigmatism for these patients acts as a prism. So they add arbitrary cylinder in their refraction to counteract that coma that the prism induces. Patient selection, very important. We talked the importance about being very, very astute on how accurate your pentacam maps are in picking up ectasia. These two maps are not equally normal, although they're flagged normal by the sign fluid device. The left map has concentric two-color steps of cornea thickness. Okay, 3. The right eye has a more oval thickness transition and 4 steps. Some have 5 steps. This, to me, although it doesn't flag on the pentacam, is suspicious for keratoconus. And by the way, these are the epithelial maps of that same patient, document clearly keratoconus, but the epithelial remodeling is hiding it from the pentacam map. Once you get into practice, it's very important to flag patients that are nasty on the phone, how to deal with patients that are interested only in the pricing of the procedure. I'll not endeavor into that. Informed consent. In my involvement in medical legal cases in the US, and I've consulted for many years as an expert on the defense of the surgeon, and mainly in Lasik lawsuits for the medical liability company as a medical expert, all of the problems were here. Informed consent. Informed consent was given after the Valium pill was given to the patient by a nurse or a technician. Oh, Mr. Smith, you just have to sign here. It's a typicality. No reason to worry about this. This is not informed consent. Patients need to be aware of all the surgical alternatives, of all the non-surgical alternatives that they have, and they have to be clearly aware of risks with a procedure. It is not uncommon that a patient will ask me, Dr. Kanellopoulos, what's the worst thing that can happen? And I do not hesitate a second. This may shock you to share with them the fact that I can die, you can lose an eye. Nobody has a contract on longevity or safety in the procedure, but I will do 100% or 150% of the effort to make this as safe and effective as possible. Let's be clear about this. These are promises broken that lead to lawsuits and unhappy patients, not bad outcomes. Remember that. These are our basic instructions for LASIK. I know this methadone is not available in the US, but it's basically chlorphenicol and dexamethasone. In the US, I use predforte and fluoroquinolone. These are a follow-up regimen, first day, first week, first month, 3, 6, and 12 months. And obviously, as I mentioned before, I'm following epithelial maps closely. You can see in the middle left epithelial map how we're seeing the transient dry eye clearly evident the first month after the procedure, and how it goes away after months of pampering the patient and also using here topical cyclosporin. We've reported on this, how Restasis can help with the transient dry eye syndrome in a lot of these patients. Incomplete flaps or complete flaps were a problem mainly with keratomes. This is what DLK looks like. You have to differentiate it from infectious keratitis. If it looks like the one on the right here on your screen, you probably have to lift the flap, irrigate, and you have to really look careful on who walks into your laser room and what's flying around in the laser room and how are the instruments sterilized. These come in batches, in epidemics, and they're a disaster for laser vision correction center. If it looks more like the one on the left, it'll go away or milder with increasing your topical steroids. But remember to avoid what we're seeing here in OCT, the fluid pocket from a steroid responder that measures normal pressures, but the real pressure in the eye is 50 after a few weeks of corticosteroid treatment. Epithelial ingrowth, we're seeing on the top left here some of the worst cases that I've seen. Obviously, if you lift, I would lift and remove it both from the stromal bed and the underside of the flap and suture that flap into place, because this epithelial ingrowth has eroded the edge of the flap here enough that even if you remove it and put the flap back on, there's still an active channel here that will invite epithelium to go back to where it was. So in my opinion, this needs suturing after removal. If it's very mild, removal alone may do the trick. This is again the central toxic keratopathy patient and how the tremendous flattening improved through the years with topical cyclosporin, artificial preservative-free, artificial tears, and preservative-free steroids. This is, you should see this video on our YouTube channel, the Laser Vision YouTube channel. This guy used to had 7 epithelial ingrowth removals, and the 7th time he tried to do it himself with his girlfriend in the mirror using a toothpick. So we felt this would be a better approach. Remove it, see how big pockets of epithelium ingrowth are present. Here I'm taking a sliver of epithelium from the underside of the flap. I'm heating the flap at 60 degrees Celsius with hypotonic water. Very careful using hypotonic water in operating rooms. If it ends up in the eye, it will kill the endothelial cells, and then suturing the flap in place, going from here to here to the 2020 result. This is, I like this slide because this is a publication we had in Cornea a couple of years ago showing the prodigy of how the epithelium remodels after LASIK and SMILE. This is our contralateral eye study, so it has a lot of statistical power because the one eye was treated with LASIK, the other eye with SMILE. You can see what normal looks like with the OCT-derived epithelial maps on the top, and how LASIK is a little bit more aggressive in the epithelial remodeling and dry eye, but SMILE is maybe smoother, but it's not null in its dry eye manifested by epithelial remodeling here. And the two look relatively similar at 3 months. LASIK looks still worse at 6 months than SMILE. But if you go out to 2 years, fine, LASIK looks slightly worse than SMILE, but both procedures are more similar than dissimilar. And unfortunately, that was the SMILE promise that did not go through for us. It did not resolve dry eye after lamellar laser vision correction. And we've reported a lot on dry eye. This is our cyclosporin A study. And dry eye, this is infectious keratitis. Unfortunately, this is one of my patients back in 1997. Thus, the quality of the pictures. You can see there's 2 infiltrates. The first thing that should come to your mind is what? 2 infiltrates in the cornea is fungal infection until proven otherwise. We're seeing here a histology specimen, unfortunately, which kind of draws the rest of the story for you, which is unfortunate. Patient had a therapeutic cornea transplant. And just a little cornea caveat: when you see hyphae in deep cornea that had a vertical orientation, you're talking about a very aggressive fungus. Acremonium here in this case, again, infectious keratitis is very rare, 1 out of 5 to 10,000 cases now. So it's far more safe in LASIK than in contact lenses, where the use of 10 years will result in 1 in 1,000 eyes getting a very serious keratitis that may require transplantation. This is a SMILE complication. I'm going to go into depth in that. We only have 15 minutes left. We're going to go into a little bit working with studying eyes prior to laser vision correction. My general advice to share with you is that whenever you spend more than 5 seconds in evaluating a patient whether they should have LASIK or PRK because something funny looks in the cornea, do PRK. Do a surface ablation. Go the safe way. And if you use some of the things we talked about before, it may be an experience for the patient more similar to LASIK than dissimilar. Patients have attached PRK with immense pain the first night, but I mentioned that using bromfenac and perhaps a smaller epithelial removal and not using dilute alcohol may help completely avoid that hardship. So here, the thing that I don't like are the epithelial maps. These maps are responding to potential early ectasia, and this for me is a no laser or if laser PRK. This is a case I saw as a medical legal consultant, had seen 6 experts in the US, big Lasik experts, some of them mentors for me. They all concluded that this was post-Lasik ectasia. This at one point carried a judgment of $7 to $8 million. If you look at the placebo disc images, fine, there's significant inferior steepening, but let's study this and let's learn a little bit what these maps show us. The anterior elevation certainly shows that there's a bump in the anterior part of the cornea. But let's look at the back side of the cornea. There's no concave corresponding area on the back side of the cornea. So the front bump is independent to the posterior imagery of the cornea. And if we look at the cornea thickness, the cornea is thinner, far away from the steeper point. So this is not an ectasia case. This is a decentered mixed astigmatism ablation. The laser decentered its ablation, treated as hyperopic correction inferiorly. It's very common with patients that invariably squeeze their eyes and through Bell's phenomena shift their eyes superiorly, so your ablation shoots inferiorly. Most of the decentrations are inferior for obvious reasons that I described. So this is not ectasia, this is just a decenter ablation that just needs a couple guided fix. And fortunately, we're able to do this here before, after, and the difference map. And again, post-Lasik, what went wrong here? One eye has ectasia, the other eye is developing ectasia. This patient is an avid eye rubber. He rubs his eyes when he sleeps under the pillow. We were the first team to publish using excimer and cross-linking for treating these post-refractive surgery ectasias, now called the Athens protocol. And these are some of the literature. I'm not going to tire you. This is one young fellow from Astoria. He was a fire department helicopter pilot. He had Lasik. Unfortunately, this young fellow developed ectasia. His whole life career depended on this. We endeavored into performing a topo-guided fix and cross-linking. He was miserable the first months that cross-linking takes to heal. We lost him 3 months later. We found out 5 years later that he's a fighter aviator with 20/10 vision. Not all of them turned that way. This is the Athens protocol using a combination of a topo-guided fix and cross-linking to treat these cases. Decentered RK, not really in our subject matter today. How to treat decenter ablations, we've reported on this many, many years ago. And topo-guided or some wavefront devices are good in this. And I talked about this. What do you do with patients that you treated a few years ago? They were plano, very happy 20/20, and 3 years later, they're 51 years old, they're a -8 myope, and maybe a lady instead of a gentleman. Look at the lens thickness. And if you've measured this prior to the surgery and it was 3.2, you have evidence here that they're into a nuclear sclerosis development and they will develop cataract. Now, your options, of course, is you can, in short term, treat with an enhancement, but if you wait a few years, you'll do a cataract procedure here. And remember this as a pro on evaluating post high myopic Lasik or PRK patients that have late recurrence of the myopia. Inlays, a very bad experience in the US. They became FDA approved, and soon after they were withdrawn by the FDA. One of the rare occurrences, this is one of our earlier experiences in Europe of a presbyopia inlay melting within 2 months and creating basically a keratolysis hole in the cornea. This is under review for publication, a small complication. And I'm going to sum up here and leave maybe 10 minutes for discussion. I hope I didn't discourage you from laser refractive surgery. All the complications that we saw here, almost all are avoidable by using a systematic approach, being very open with refractive surgery patients. Remember, these patients usually deal with our procedure, our craft, our medical intervention as a consumer good. And this is a very important part at least in my opinion, to differentiate in your clinical practice. I never want to sell a procedure. I will never use the terms, everything's going to be perfect. I will never use the term, your vision is going to be perfect. I guarantee you. I'm not timid. I have been known to treat cases that were, for some people, not optimal for laser vision correction. But I do believe that being fair and honest with patients is the best building block for having a successful practice and sleeping well at night. And just to sum up, proper preoperative evaluation, being familiar, especially in your first steps with the device that you're using, your team being coherent and adherent to your standards, and continuously being in touch with the patient and encouraging them to comply with your instructions will make, number one, the procedure as perfect as possible, number two, your patient as comfortable as possible, and number three, offer them maybe the most successful procedure in medicine altogether. These are people who go from being count fingers vision to 20/10 vision within hours. And this is a strong intervention that medicine has to offer to patients these days. So I'm leaving 10 minutes for discussion. If you have any questions, if you want me to run through any of the, this is, by the way, the view from my office in Mykonos. Weather's going to get better here soon next month, so I'll be there Thursday to Monday. And now you are picking up some of the reasons that I'm full-time practice in Greece and part-time in New York for the last 15 years. But if you have any questions, even in the videos, I can roll some of them again and talk about it. And I want to thank NYU and our resident prof for the opportunity for me to share your experience. It's really an honor for me and a lot of pleasure. Yes, yes, I'm familiar with it. Thank you for giving me the opportunity. I really enjoyed it. Look forward to doing it again, anytime. Yeah, Mykonos is one of those special places. Thank you, guys. I hope you continue through the hardships of COVID and obviously residency training. And I'm here available for any of your questions. I'm actually going to be in New York the week of March 14th. And if any of you are interested in getting your feet wet in a case report or something that's related to cornea, refractive surgery, we have about 40 orphan case reports that are just looking to be adopted by a resident that is seeking to build up their CV. We'll be happy to help you through that. Absolutely. Thank you. Have a great weekend. Thank you. Okay, I'm signing out. Możemy sign out.